Speaker on. Speaker on. आवाज आ रही है बिस्मिल्लाहिर्रहमानिर्रहीम। Hello, respected seniors and my dear colleagues. I welcome you all on this hybrid evening workshop on the behalf of Pakistan Society of Nuclear Medicine. This workshop will include 3 talks. Initial 2 talks will have a brief representation of the anatomy, and the final talk will have a detailed introduction of Pep Ct artifacts and a few interesting cases. At the end, we have a short question answer session. You all know that PSNM has arranged 7th National PSNM Conference, and today is the 2nd day of the pre-conference workshop. Yesterday, we had a workshop on quality assurance and radiation protection. And today's workshop will elusively focus on the Pet Ct, anatomy and imaging artifacts and interesting cases. Before we start the event, I will request Hafiz Muhammad Tawqir to recite few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لقد جاءكم رسول من أنفسكم عزيز عليه ما عنتم حريص عليكم بالمؤمنين رؤوف رحيم. فإن تولوا فقل حسبي الله لا إله إلا هو عليه توكلت وهو رب العرش العظيم. صدق الله العظيم. In the name of Allah, the entirely merciful, the specially merciful. There has certainly come to you messenger from among yourself. Grievous to him is what you suffer. He is concerned over you, and the believer is kind and merciful. But if they turn away, O Muhammad sallallahu alaihi wasallam, say, sufficient for me is Allah. There is no deity except Him. On Him I have relied, and He is the Lord of the great throne. وَمَا عَلَيْنَا إِلَّا الْبَلَاغُ.
Let's start the regular proceeding of the today's session. I am Dr. Faisal Hassan, currently working in role as a Principal Medical Officer. Along with me, Dr. Awais, we both will be moderating this session. On the behalf of President PSNM, I welcome you all for this workshop. We will start with a short talk by President PSNM, Dr. Akifullah Khan. Then we will proceed for the first. Then afterwards, we will proceed for first a talk by Professor Asim Shaukat.
In the name of Allah, the most beneficent and merciful, I welcome all the distinguished speakers, academicians, and participants to the second pre-conference workshop of the 7th PSNM annual meeting. The whole world is in the grip of COVID-19 pandemic. Some of our colleagues are still infected with the COVID-19. We wish them a speedy recovery, while some of our colleagues have fought the disease. We wish them good health in the future as well. While the others who have not yet encountered the infections are at the risk, and we suggest them to adhere to the precautions and get vaccinated so they may be safe in the future. This conference is also being joined by the Chinese Society of Nuclear Medicine and the Arab Society of Nuclear Medicine. So the coming 3 days will be studied with interesting topics related to nuclear medicine, endocrinology, oncology, and other allied topics. This pre-conference workshop is primarily focused on the cross-sectional anatomy and understanding of the cross-sectional anatomy. After the introduction of hybrid imaging, CT has become an important component of the diagnostic arena. And in nuclear medicine, most of our nuclear medicine colleagues are not that well familiar with the CT component of the hybrid imaging. So we have endured to make our colleagues familiar with the cross-sectional anatomy while reading the hybrid imaging. So in this workshop, we have got 4 talks. The first 2 talks are primarily on the hybrid imaging CT part, and this first talk is by Dr. Asim Shaukat, who's head of the radiology and in the allied hospital Faisalabad, and he'll be talking about the cross-sectional anatomy of the head and neck. We, being the nuclear physicians, need the head and neck CTs very frequently for the local recurrences of the carcinoma thyroid. So coupling a CT component with the whole body or with the radioiodine scan can better delineate the hot spots on the hybrid imaging. So I wish and I hope all those nuclear physicians who are actively involved in the management of carcinoma thyroid will be helping from these deliberations. The second talk is by Professor Dr. Sadaf Arooj, who's Associate Professor of Radiology in King Edward Medical College, University, Mayo Hospital, Lahore. And she'll be talking on the cross-sectional anatomy of the chest and abdomen. And that would also be a very interesting talk. In the second part, my friend, my class fellow, Dr. Arzu Fatima, would be talking about the PET CT pitfalls, and then she'll be talking about some interesting teaching files in an interactive session. So I wish you all a very happy learning experience. This workshop is primarily being organized by Dr. Owais in collaboration with all the Executive Council members. I congratulate Dr. Owais bin Qadir Gill for holding and organizing this event and making us available all these honorable speakers like Professor Dr. Asim Shaukat, Professor Dr. Sadaf Arooj, and Dr. Arzu Fatima. I'm thankful to the management of all the PAEC medical centers all over the country who are helping us in approaching our audience across the country. So I'm thankful to all those who are helping us in the better dissemination of the conference, of this workshop. I'm also thankful to all the private and the non-PAEC medical centers like those in the Army and Aga Khan and the Shaukat Khanam Hospital who are telecasting or who are hosting these events in their respective institutes. Due to COVID-19, this event is being organized through virtual session, and I think that the gist and the liveliness of a live session is not there, but we are being watched by a much larger audience. I hope you enjoy this session. Thank you all of you for your patient listening. Assalamu alaikum.
Thank you, sir. Hybrid imaging is the front face of the nuclear medicine, and with emerging techniques of fusion imaging, this has increasing role in the both diagnosis and the management. Anatomy is the basic part of the hybrid imaging. If you have a good anatomy, if you have a good knowledge of CT anatomy, of course, the interpretation of PET CT and PET MR is very valuable and is more result oriented. We will start with our first presenter. He is Professor Asim Shaukat. He is head of the radiology department at Allied Hospital, Faisalabad. He has a vast experience of teaching the students. He is examiner of College of Physicians and Surgeons of Pakistan, currently heading the leading hospitals of Faisalabad. He will be introducing the basic anatomy of the head and neck, basic cross-sectional anatomy of the head and neck. His talk is mainly aimed at CT anatomy of the head and neck. If any questions that we will include at the end of the session.
For letting me share this presentation with you. I have been assigned the topic of anatomy of neck. So today our topic of discussion would be anatomy of neck, and I hope that this will be of much benefit to all of you. My name is Professor Dr. Asim Shaukat. I am Head Department of Radiology in Faisalabad Medical University, Faisalabad. So we will be covering multiple aspects of anatomy in this presentation. These are the plain radiographic images which show you the anatomy of neck. From here you can look, this is the lateral view of the neck, and this show you the hyoid bone. This is a very strong landmark of hyoid bone and the epiglottis. Then comes the thyroid cartilage. This is the airway that is passing through the regions of the cricoid cartilages, the vertebral column, and the pre-spinal spaces. These are the osteophytes formation. And when we look further toward the spine, these spinal lines, the dense and the anterior vertebral line, the posterior vertebral line, spinolaminal line, spinous processes. All of these lines are very important when you consider the patients of trauma and any other abnormality in which these lines are distorted. Then you get to know that there is something wrong going on there. And as we discussed, the prevertebral space, that is at the level of C2 around 7 mm and at C6 level around 22 millimeter level. Again, when we divide the neck, we divide it into the nasopharyngeal, retropharyngeal, retrotracheal spaces in the neck. It is short in these upper spaces of the nasopharyngeal region and retropharyngeal regions, and gets to slightly larger in the retrotracheal spaces. If it gets these spaces, the sizes get distorted, you get an idea that there is something wrong over there. Pharynx is a muscular tube. It extends from the base of skull to the level of cricoid cartilages, approximately C6, where it is continuous with the esophagus. Now it has components of nasopharynx, the oropharynx, and hypopharynx. This is the cut through this is the nasal cavity, the maxillary sinuses, and the nasopharyngeal region, having the thoracotuberous lateral pharyngeal recesses, the carotid vessels passing through, and this is the basi-occiput region, the base of skull. Whatever maxillary sinuses, these are the pterygoid plates, the pterygoid muscles, the masseter muscle, the longus colli, the carotid vessels, and the jugular space, and this would be the nasopharyngeal region. Now the oropharyngeal region at the level of the tongue. This is the portion of tongue, the superior alveolar arch, the palatine recesses, the palatine tonsils, the parotid glands over here, the digastric muscles, the sternocleidomastoid muscle over here. Further, of the oropharynx, the floor of mouth muscles, the region of tonsils, again sternocleidomastoid passing there, the neck vessels, and the strap muscles of the neck passing through. Again, the mandible at the level of oropharynx, the floor of mouth. You go further down, then comes the submandibular gland region, the sternocleidomastoid muscles, the inferior alveolar arch. Now we go, this was the region we had discussed, the nasopharynx, the oropharyngeal region, then you come to the hypopharynx. Here, the hyoid bone, sternocleidomastoid muscle passing through, the submandibular gland region, and the vessels passing through the region. Glossoepiglottic fold, pharyngoepiglottic folds over there, pre-epiglottic fat, ariepiglottic folds, thyroid cartilages, sternocleidomastoid muscles, muscles of the neck, and these are the false vocal cord. You can appreciate the fat over there in the region. This is the false vocal cords, and then the jugular vessel passing through. Now after that, you come to the larynx. It extends from the base of tongue to the trachea, lying anterior to third to sixth vertebrae, lies between the great vessels of the neck, and is covered anterior by strap muscles, fascia, and skin. The CT axial sections will show you the supraglottic level, the glottic level of the vocal cords. Basically, it's the vocal cord level, the glottis level, then you have the supraglottic portion and an infraglottic portion. Just as you look at these pictures, the regions of the false cord and the true cord, then you have a supraglottic component. This would be a glottic and an infraglottic component. Supraglottic level would contain the piriform sinuses of hypopharynx, area epiglottic fold, epiglottis, epiglottic folds, belliculi, base of tongue, hyoid bone, which I've seen already. Again, this would be hyoid bone, the belliculi, the piriform sinuses, the hyoid bone again, and then you can see these are the thyroid cartilages, the laryngeal inlet, area epiglottic folds, and the piriform sinuses. Neck anatomy is slightly complex. You have to concentrate on this, and if you know the anatomy, it would be very easy for you to get through to the pathologies. Then the paralaryngeal spaces are there, and you come to the glottic level. It which consists of the vocal folds, the elliptical opening between them. The paraglottic spaces at this level have soft tissue density due to the presence of thyroid muscles. Now, the anterior commissure, the region of the vocal cords, retinoid cartilages, thyroid cartilages, and the posterior commissure. This is the glottic level. False vocal cords would be having some fat in it, and the true vocal cords are basically solid-like things. Just above the level of true vocal cord, you will be getting the false vocal cords. Again, these are the strap muscles of the neck, the prevertebral muscles, sternocleidomastoid muscles, and the carotid and the jugulus passing through the region. The infraglottic level, the larynx is more circular and cricoid forms a complete ring. The cricothyroid membranes can be seen. Normal subglottis is lined only by a thin layer of mucosa, hence any additional soft tissue is pathological. The thyroid gland, the isthmus are the lower levels, the esophagus, and the muscular planes passing through the. And these are the coronal CTs, these are the false vocal cords, and these are the true vocal cord levels. But now I will dwell a bit about these things over here. And you basically you get to know the anatomy, and when you are through with the anatomy, it would be very easy for you to recognize the pathologies which are in that region, and you can always find pathologies when you have complete command on the anatomy. Now, as you further know, the neck, these are the things which are included. Further down are the thyroid gland in it. Gland has its own and very important anatomy. It has two lateral lobes in between isthmus. I think the ultrasound would be the best modality to image a normal thyroid, the thyroid glands, the isthmus, the carotids on the side, and the muscle planes on the back. This is the esophagus that is passing through you. On CT, it is basically an enhancing area. This is an MR enhancing area of the thyroid. The parathyroid glands, you know, these are 4 in number, so 2 superior and 2 inferior. Normal glands are very small, and generally you don't get to image them unless there is some pathology in it, and it would look like something like this on an ultrasound scan. The neck vessels passing through the region, the arch, the major vessels, the right-sided brachiocephalic one, making the right subclavian vertebral and right common carotid, left and common carotid having a separate origin and subclavian giving origin to the vertebral artery. And this is the carotid space in which these vessels are passing through. I will touch about these spaces. Now, this is very important thing when you go to have to handle the surgical things. The neck has been divided into multiple spaces. I will just touch briefly upon these spaces so we get an idea of what's happening. These are called cervical spaces. These are facial planes and compartments in the neck. It helps you localize the lesion and narrow down the list of differential. You get to know in which space it is, what is normal content of the space, the radiological pattern recognition is integral. Now it is again divided into these multiple levels: the suprahyoid neck, the suprahyoid and infrahyoid neck, and infrahyoid neck. The spaces which are confined only into the suprahyoid will be parotid space, masseter space, submandibular space, parapharyngeal spaces. And those would be confined only in the infrahyoid, that is beneath the hyoid bone, the anterior cervical space, suprasternal space, and strap muscles. And those which are continuous into both compartments would be the carotid, visceral space, pharyngeal, retropharyngeal, prevertebral, posterior cervical, and sternocleidomastoid with trapezius. So these are basically the important neck spaces, and you should be able to now again identify these. These are hyoid bone and the suprahyoid and the infrahyoid compartments. Now this is a brief discussions about these pharyngeal and the rest of the spaces over there. The pharyngeal mucosal space, the contents of it, and the location of it. Again, the parapharyngeal space. Basically, the anatomy would remain the same as we have already discussed, and you can find these at the spaces which are continuous along the fascias, and you get to know their contents and the pathologies associated with them. This is the modern day anatomy now that you should label things according to the anatomical spaces. And as you can find, this is the normal side, and on the parapharyngeal space on this side, you get the pathology which is enhancing in nature and showing you asymmetry as well. Again, the carotid space, it is continuous at the suprahyoid level and at the infrahyoid level, and the relations that are continuous with this. The contents of these spaces and the pathologies associated with these spaces get you to narrow down the differentials that are passing through the region. Another important space would be the parotid space, enclosed by superficial layer of deep cervical fascia. The contents, the parotid, the intraparotid nodes, the external carotid artery, and the internal memory artery, retromandibular vein, and the facial nerve. The submandibular space, the sublingual space, the retropharyngeal space. As you can look at this, the space continuous along the suprahyoid level and the infrahyoid level, and the Z tracking down. You can easily suggest the pathologies which are continuous with these spaces. Now, this space on a healthy patient, you do not distinguish. It's space located behind the retropharyngeal space, which connect the deep cervical spaces to the mediastinum. So anything which is infiltrating into that space like fluid or pus, it would basically track down below into the thoracic region. The prevertebral space, again the stress point of today's presentation again would remain that the basic anatomy of the neck, as we had discussed in these cross-sectional images, that is very important. You can go through it again and again, and you should try to have a grasp on it. Only because of the fact that you have the grasp on this anatomy, you can distinguish between the pathologies, and you can try to narrow down your differential. Then comes the anatomy regarding the thyroid gland and the parathyroid glands and the neck spaces. The neck spaces are very important surgically. If you are able to identify a pathology basis involving a specific space, you can narrow down your differential, and you can have a look on what sort of pathology that is passing through the region. So I am very thankful to the presenters for allowing me to have this share on this anatomy of neck, and I would be available for any sort of questions which do arise in your mind. Thank you very much.
Thank you, Professor Asim Shaukat, for the wonderful talk on anatomy of head and neck. So our next speaker for today's session is Dr. Sada Farouj. She has working as Assistant Professor of Radiology, King Edward Medical University, New Hospital, Lahore. She has presented journal and research papers in various international and national conferences. So I request Dr. Sadaf to please deliver a talk on CT anatomy of abdomen and chest. Over to you, Dr. Sadaf.
Bismillahirrahmanirrahim. Topics assigned to me to teach you are cross-sectional CT anatomy of chest and abdomen. We'll be first talking about the cross-sectional CT anatomy of the chest with perspective of bed. Bismillahirrahmanirrahim. Topics assigned to me to teach you are cross-sectional CT anatomy of chest and abdomen. We'll be first talking about the cross-sectional CT anatomy of the chest with perspective of PET CT. I'm Dr. Sada Farouj, Assistant Professor of Radiology, King Edward Medical University, Mayo Hospital. There are many indications of the CT chest. We'll be largely considering the staging of the lung neoplasms and metastatic workup. Usually not much preparation is required, and fasting for at least 4 to 6 hours is required for injection with IV contrast. 10 mm sections are taken from the lung apices to the CP angles. We see different window settings, like for CT chest we need mediastinal window, lung window and the bone window. Few words about the mediastinal vasculature. This is the level of the arch of aorta, like you can see from the gross anatomy, and this is a contrast enhanced CT scan. This is the arch of aorta, this is superior vena cava, and this is trachea. These are the lungs. Slightly upper level from the previous one. This is the level of left common carotid artery. Here we can see the brachiocephalic trunk. Here you can see this is the main pulmonary trunk. This is ascending aorta and this is descending aorta. Here is the superior vena cava. This is how we divide the lungs into lobes. This is the oblique fissure, this is horizontal fissure in the right lung, It divides the lung into upper, middle and lower lobes. And this is the left lung. Here you can see there is no horizontal fissure, and the oblique fissure divides the lung into left upper lobe and part of lingula and left lower lobe. While seeing the CT scans of the lung, you can see that at the level of the trachea, you can demarcate this is the upper lobe. On the right side, this is the left upper lobe. At the level of the heart, the anterior 1/3 of the lung is the middle lobe on the right side and the lingula on the left side, and posterior 2/3 is lower lobes. Here you can see this is the medial segment of the right middle lobe. This is the lateral segment of the right middle lobe. Here on the left side, this is the inferior segment of the lingula, and this is the superior segment of the lingula. What is bronchopulmonary segmental anatomy? It describes the division of the lungs into segments based on the tertiary or segmental bronchi. Each segment has its own pulmonary arterial branch, and thus the bronchopulmonary segment is a portion of the lung supplied by its own bronchus and artery. Each segment is functionally and anatomically discrete, allowing single segment to be surgically resected without affecting its neighboring segments. Right upper lobe contains apical segment, posterior segment and anterior segment. Right middle lobe contains lateral segment and medial segment, and the right lower lobe has superior segment, medial segment, anterior, lateral and posterior segments. The left upper lobe contains apico-posterior segment, anterior segment, superior lingular, inferior lingular segment. Left lower lobe contains superior segment, anteromedial segment, lateral and posterior segments. This is a glimpse of different pathologies, just to show you how the anatomy helps us to detect the pathology. This is the left part of the cystic lesion is seen with the thin walls in the left upper lobe. Here you can see this is the part of the lingula, and here we have lower lobe, and there is a thick walled cavity. Here in this segment you can see this is the part of the left lower lobe. And this is this is a pulmonary nodule in the left upper lobe. Now we'll be talking about the mediastinal lymph node map. It was proposed by International Association for the Study of the Lung Cancers. This defines 7 zones of the mediastinal lymph nodes, which are further subdivided into 14 stations, and most stations are again subdivided into right and left. So this is the whole lymph nodal map of the mediastinum. Let's start with the station 1. These are the low cervical, supraclavicular and sternal notch lymph nodes. The midline of the trachea serves as the boundary between stations 1 right and 1 left. The superior border is made by the lower margin of the cricoid cartilage, and inferior border is by the clavicles or the upper border of the manubrium. This may be called as thoracic inlet. So these are lymph nodes of the group 1, and these include low cervical, supraclavicular. This is contrast in our CT scan to show you what is the location of the station 1 lymph nodes. Structures anterior to the line bisecting the visible sections of the first ribs lie within the neck, and structures posterior to this lie within the superior mediastinum. Let's talk about the station 2 lymphadenopathy. These are upper paratracheal lymph nodes. The left lateral border of the trachea serves as the boundary between the stations 2 right and 2 left. 2 right nodes extend to the left lateral border of the trachea, and 2 left nodes are located to the left of the left lateral border of the trachea. I will be showing you the images of these nodes, and I will also be showing you a CT scan so that you can understand it better. The superior border of these nodes is made by apex of the right lung, pleural space and upper border of the manubrium. Inferior border is made by the intersection of the caudal margin of the left brachiocephalic vein on right side and by the superior border of the arch of aorta on the left side. So here you can see these are the 2 right nodes, and here slightly lower is the 2 left node. This is the station 2 left. Here we have our this blue color. This shows the 2 right lymphadenopathy, and this lighter blue color, this shows the 2 left station. The image shows is below the level of the thoracic inlet and above the level of the intersection of the caudal margin of the left innominate vein and trachea, and it shows station 2R and 2 left. This is the right node and this is the left sided node. What about the station 3? These are the prevascular or the prevertebral lymph nodes. 3A nodes are not adjacent to the trachea and they are anterior to the vessels. The midline of the trachea serves as the boundary between right and left sided stations 3A. 3P or 3 posterior nodes are behind the esophagus, which is prevertebral. The superior border of 3A is made by the apex of the chest or the thoracic inlet, inferior border by the carina, anterior border by the posterior surface of the sternum, posterior border by the anterior border of the SVC on the right, and left CCA on the left side. 3P or the posterior lymph nodes. These are superiorly bounded by the apex of the chest or thoracic inlet, inferiorly by the carina, anteriorly by the posterior wall of the trachea. These are the 3A, 3 anterior lymph nodes, and these are the 3P, station 3 posterior prevertebral nodes. This is an axial CT image obtained below the level of the thoracic inlet and above the level of the carina. It shows station 3A in the green area. This one, this is the prevascular station, and here the 3P, these are the posterior station 3 lymph nodes. A goes for aorta, T for trachea, this is azygous vein, here we have esophagus. So what are the station 4 lymph nodes? Station 4 lymph nodes are lower paratracheal lymph nodes. The left lateral border of the trachea serves as the boundary between stations 4 right and 4 left. 4 right nodes extend from the right to the left lateral border of the trachea. The ligamentum arteriosum separates the station 4 left from station 5. Superior border of the 4 right is made by intersection of the caudal margin of the left brachiocephalic vein with the trachea, and inferior border is made by lower border of the azygous vein and right tracheobronchial angle. What are the borders of 4L? The superior border is upper margin of the aortic arch, and the inferior border is the upper rim of the left main pulmonary artery, left tracheobronchial angle. I'll be showing you this shortly. Here we were talking about 4 right and 4 left nodes. So these are the 4 right nodes and these are the 4 left nodes. Contrast in our CT scan at the level of the descending aorta. Here you can see this is the 4 right node and here we have 4 left node. This is the azygous vein, ascending aorta, descending aorta. What are the station 5 lymph nodes? Located lateral to the aorta and the pulmonary trunk, these are called subaortic lymph nodes. These are located in the aortopulmonary window lateral to the ligamentum arteriosum. This is the level 5 lymph node. Here we have these level 5 lymph nodes in the aortopulmonary window. What are station 6 lymph nodes? These are the para-aortic lymph nodes, anterior and lateral to the ascending aorta and arch of aorta. This is anterior and lateral to the ascending aorta and arch of aorta. Here we have this station 6 node. Here we have this station 6 lymph node. What are station 7 lymph nodes? These are easy to remember. These are subcarinal lymph nodes. Here at the level of the carina, this is the right main bronchus, this is the left main bronchus, and in the center this is subcarinal lymphadenopathy. Station 8 are the paraesophageal lymph nodes. These lie adjacent to the wall of the esophagus. Here, this is the esophagus and this is station 8. Station 8 covers whole of the length of the lower esophagus. Station 9 are the pulmonary ligament lymph nodes. Here, this is. These are the Porteros 11R and 11L lymph nodes. What is station 12? These are the lobar lymph nodes adjacent to the lobar bronchi. So this was the mediastinal lymph node plan. It included supraclavicular lymph nodes level 1. Then 2 to 6 are the superior mediastinal lymph nodes. 5 and 6 are the aortic lymph nodes. Inferior mediastinal lymph nodes are 7, 8 and 9. Hilar lymph nodes and lobar segment levels are 10 to 14. What is the lymph node staging of the lung cancer? 0 is no lymph node metastasis, and 1 is metastasis in the ipsilateral levels, and 2 is metastasis in ipsilateral levels 2 to 9, and 3 is the metastasis in level 1 or any contralateral lymph node. There are others or non-renal lymph nodes also. These are internal mammary, posterior intercostal, prevertebral, etc. So this is a section break, and we'll be shortly starting cross-sectional anatomy of the abdomen. So before starting the cross-sectional anatomy of the abdomen, let's talk about what are the most common indications for the PET-CT. These are for the assessment of morphological and functional characterization of the pulmonary nodules or mass, with staging of the cancer, screening for metastasis that might not be detected by CT alone. PET-CT is also indicated for the radiotherapy planning and for restaging the lung cancer after the treatment. These are various parts of the which we can see in the contrast enhanced CT of the abdomen. This is the part of the stomach. Here you can see this is stomach. This is a cross section of the CT at the level of the stomach. These are different parts of the stomach. This is fundus. This is body of the stomach. Here we have the antrum. This is called pylorus, and here we have esophagus. Knowing cross anatomy is must before knowing the cross-sectional anatomy. So here we have first part of the duodenum, this is the second part of the duodenum, and this one is the third part of the duodenum. Here you can see this is liver, here we have gallbladder, this is right kidney, this is left kidney. What is this? This is spleen. Here you can see part of the pancreas. Where is the jejunum? This is on the left side. This is part of the jejunum. Here you can see the jejunum. This is the whole jejunal loop. Look at the cross anatomy. Here we have this appendix. This is the ileocecal wall. Here you can see the part of the ileocecal wall on a cross section, and on this axial CT section you can see the appendix as a tubular structure. Now looking at the gross anatomy, this is the ascending colon, this is transverse colon, splenic flexure. Here near the spleen, this is the splenic flexure of the colon. Now this is the descending colon. Here we have the descending colon. This is the sigmoid colon. Here you can see this typical appearance of the sigmoid colon. Now we'll be talking about the role and importance of the liver in CT imaging. This is the liver segmental anatomy. The delineation of the segments is based on the fact that each segment has its own dual vascular inflow, biliary drainage, and lymphatic drainage. Generally, each segment can be conceptualized as wedge-shaped with the apex pointing towards the hepatic hilum, where a single segment branch of the portal vein, hepatic artery, and bile duct enters it. These are the hepatic veins, and these divide the lobes of the liver into different parts. The right hepatic vein is located in the right intersegmental fissure, and it divides the right lobe into right lateral and medial sections. Middle hepatic vein lies in the main lobar fissure. It divides the liver into right and left lobes. So this is the right lobe of the liver, this is the left lobe of the liver, and this is our middle hepatic vein. The left hepatic vein is located in the left intersegmental fissure. It divides the left lobe into the left medial and lateral segments. What is the horizontal plane which divides the liver? The horizontal plane which divides the liver is the portal plane, where the portal vein bifurcates and becomes horizontal, dividing each section of the liver into superior and inferior segments. So here we have segment 2, segment 4A. Slightly lower down is segment 4B. This is segment 8 of the right lobe of the liver. This slightly posterior one is segment 7 of the right lobe of the liver. Lower down at the level of this portal vein horizontal portion, these are the inferior segments. This is the left lobe of the liver showing segment 3. This is the 4B segment. This is 5 segment. This is 6 segment. This is segment 6. This comes near the kidney. This segment 5. This comes just near the gallbladder. This is an annotated image at the level of the liver and pancreas. This is the right lobe of the liver. This is the left lobe of the liver. Here you can see this is pancreas. This is portal vein. Here we have IVC. This is right kidney. This is left kidney. This is spleen. Here you can see this is the lateral left segment. This is medial left segment. This is anterior right segment. This is posterior right segment just near the kidney. This is segment 6, and here we have this caudate segment of the liver. This is level for the bifurcation of the right and left portal venous branches, which divides the segments into superior and inferior parts. So here we have this left hepatic vein level, middle hepatic vein level, and right hepatic vein level. This is the level of falciform ligament. This is the gallbladder fossa, and this is the right hepatic vein. Again about the segmental anatomy, this is the medial part of the left lobe. This is lateral part of the left lobe. This is anterior part of the right lobe. This is the posterior part of the right lobe. Here we summarize the same thing. This is the left lobe of the liver, segment 2 and segment 3. This is segment 4A, segment 4B. In the right lobe, this is segment 8, and the lower down is segment 5 that we have already told you that this is along the gallbladder. Segment 6 is along the right kidney. This is segment 7, this is segment 8, and quadrant lobe is called as segment 1 of the liver. Now again about the gross anatomy and the cross-sectional anatomy. This is the pear-shaped gallbladder and common bile duct. This is the gallbladder. Here you can see the gross anatomy structure. This is the spleen, and here you can see on the CT this is the shape of the spleen. Adrenal glands are very important structures, especially if we talk about the PET CT scanning and in the oncology patients. So this is a Y-shaped right adrenal gland. This is the left adrenal gland. A diagram to show you the body and a tail of the pancreas. This is the body and tail of the pancreas on a contrast enhanced CT scan. This is the pancreatic head. Few words about the abdominal musculature. Talking about the gross anatomy, aorta is lying towards slightly left of the midline. It has 5 major branches in the abdomen, which are celiac trunk, superior-mesenteric artery, renal arteries, inferior-mesenteric artery, and the iliac arteries. Here we have this seagull-shaped appearance. This is celiac trunk. Celiac trunk is a large vessel which arises from the anterior part of the aorta. Slightly low down, this is superior mesenteric artery. Here you can see the superior mesenteric artery. Here lies the inferior mesenteric artery. This is the level of the aortic bifurcation. Aorta is divided into right common iliac and left common iliac arteries. This is right common iliac artery. This is left common iliac. These are the bifurcation of the aorta. This is the right internal iliac artery, and this is the external iliac artery. Here we have this is external iliac artery and this is internal iliac artery. Talking about the venous drainage of the abdomen, this is this large structure. On the right of the aorta is IVC. This is portal splenic confluence. And only few words about the lymph nodes of the abdomen. This is gastrohepatic ligament lymphadenopathy. Abdominal groups are portocaval lymphadenopathy. This is the space for aortocaval lymphadenopathy, this being the aorta, and this is IVC. This left to the aorta, if structure is present, that means this is left para-aortic lymphadenopathy. Within the mesentery, these can be mesenteric lymphadenopathy groups. At the level of aortic bifurcation, we have aortic bifurcation lymph node groups. Pelvic groups can be along the common iliac artery. Peritoneal spaces. The transverse mesocolon divides the peritoneum into supramesocolic and inframesocolic spaces. Like here we have this Hodgson pouch. Few cases. This is PET CT axial section, which shows two nodules here in the right supraclavicular area, and considering their character on the PET CT, they were called metastatic lymph nodes, and their histopathology confirmed that these are metastatic. A case just to show you the importance of the PET CT. Here you can see on the PET image there is slightly increased activity in the right side of the midline, which was taken as the ureteric activity. But when you see at the coronal section of the CT scan, you see a lymph node just adjacent to the right ureter. PET CT axial section showing a midline hypermetabolic activity. On CT scan, this is in the body of the pancreas. Here you can see on the CT PET image that there is gross hypermetabolic activity within the level of the pelvis, and on CT scan this is part of the sigmoid colon, which shows diverticulitis. Here on the PET CT you can see a small hypermetabolic focus in the anterior part of the abdominal cavity, and on the CT scan this is part of colon. On a PET CT you can see these are the adrenal glands, and here on CT scanning you cannot appreciate very much enhancement of these adrenal glands, suggestive of metastasis. So that's all from me, and thank you very much.
Thank you, Dr. Sadaf, for your talk on CT, chest, and abdomen. Now, if you audience has any question, then Dr. Sadaf is here live with us to answer your question. Can we have any question for Dr. Sadaf? Or should we move to our next talk? Dr. Zahir has a question that why two are lymph nodes in the mediastinum, both on the left side of lateral part of the trachea? I guess that's what the slide says. So can you please reshare your slide and so that we can solve this ambiguity as question raised by Dr. Zahir? Dr. Sadaf, can you hear us?
Yes, yes. Let me share the slide. I got the point. I think this question is about this slide.
You
Or
please
this
share
one,
your
There.
screen. Yeah. Can you please
Okay.
share the screen and you can share the same slide which he is talking about?
Yes, I'm trying to share the screen. Can you see this?
No, screen is not yet shared.
Achha, what I get from the question is these are actually 4 stations of 2. On right side, there are 2 lymph nodes which have been pointed out, and on left side, there are other 2. So at these areas, whatever lymph node is present, that would be called as 2R. Okay. So this is the standard manifestation or standard way of labeling these. I cannot share this actually right now.
Dr. Zahid, can you hear us? Are you with us, Dr. Zahid? I think Dr. Zahid is lost. May I ask the admin to unmute the Dr. Zahid first so that he can ask his question by himself? Admin, please unmute Dr. Zahir. Is it possible for you to unmute him? I think we don't have the option to unmute Dr. Zahir. So Dr. Zahir, you can just type in your queries. If you are satisfied with the answer, should we proceed further? I think maybe there is some labeling issue in the slide. As she has explained that the level is 2R, whether it is on right or left, but the system that has been designed for this classification of the mediastinal nodes, it states 2R.
Yes, it means at these 4 places, these can be 2 R's and 2 L's. On left side, 2 of the stations, and on right side, 2 of them. So total of 4 points where these can be present. I hope you understand this. I tried sharing the screen, but I think, unable to do this.
It's okay. Dr. Zaid has just typed in that he's okay with that. So if there is any other question, then please put it on or type your question in the chat box. Otherwise, we should move to our next speaker. I think there is no more question right now. So thank you, Dr. Sadaf. Thanks again for your wonderful talk and for your time. And now we move on for our next speaker. She's Dr. Arzu Fatma. Dr. Arzu Fatma is currently working in Mole as head nuclear medicine and Pet Ct imaging. She's DCMO, Deputy Chief Medical Officer. And today she's going to present about the common pitfalls which we see in the routine PET-CT imaging. Afterwards, he will also discuss various staging cases. So over to you, Dr. Arzu Fatma. Welcome to you this forum, and please share your presentation. Admin, please unmute Dr. Arzu and share his slides.
आ क्यों नहीं रही मेरी?
जी मैडम, ये सारा इनबॉक्स है आपका।
नहीं।
ये इधर से
ये मेरे दिक्कत है, ये बाद में जाती हूँ, ठीक है? अब आप अपने काम पे चले जाएंगे। तो मिनिमाइज करते हैं उसके चलिए।
Dr. Arzu, please unmute your microphone because we can't. No, it's unmuted. Please continue.
Unmute.
तो अनम्यूट है। इन्होंने वीडियो ऑफ की।
We can hear you now.
नहीं, मेरी तो उनके पास प्री रिकॉर्डेड है ना। मेरा ख्याल है मैं फोन करती हूँ, समझ नहीं है।
We can hear you.
मैडम इधर
your slide.
लाइट शेयर करने में
करें ना, आप करें।
मैडम इसमें नहीं ऑप्शन आ रही, अलाउ नहीं किया।
We do not have this option यहाँ पे, मैंने आपको ये भेजी भी है, उसमें कोई इशू आ रहा है?
Okay, हम slides play कर देते हैं, then you stay live with us.
नहीं, आप जो आपके पास ऑलरेडी है, you will not be able to do that.
We are playing your presentation, so you stay live with us for the question answer session.
Okay.
Admin, please, can you play the slides at your end?
Assalamu alaikum. I will be talking about a hybrid imaging modality that is PET-CT. This is going to be the layout of my talk. Few words about PET in general, major indications of FDG PET-CT, the rationale behind it, and normal distribution of FDG in the body. Then I will come to the first part of my talk, an overview of the pitfalls generally encountered during oncologic FDG PET-CT. During the second part of my talk, I will be showing you some interesting cases from InMole PET-CT archives. FDG PET-CT is continuing to have an ever-increasing role in staging malignancy, evaluating tumor response to treatment, evaluating indeterminate masses discovered on CT, MR, and ultrasound. Many treatment decisions are primarily based upon the functional metabolic information acquired from PET-CT. It is undoubtedly critical for the interpreting physician to be aware of the potential pitfalls that may lead to an erroneous diagnosis. There is a long list of indications if you wish to look at the SNM and ENM guidelines. Coming to the rationale behind FDG PET-CT. As the name implies, FDG, or fluorodeoxyglucose, is an analog of glucose that shows increased uptake in many cancer cells as compared to the background tissues due to a variety of reasons. Number one, increased expression of glucose transporters in the cell membranes of cancer cells. Number two, changes in the enzymatic activity within the cancer cells. This is a rather nice pictorial representation of glucose and FDG. As you can see, both enter the cells by glucose transporter membrane proteins. Once inside the cell, both are phosphorylated by hexokinase, and this process can be reversed by glucose 6-phosphatase. Now, phosphorylated glucose is available to be further metabolized by the cell. Phosphorylated FDG, on the other hand, cannot either go out of the cell or be further metabolized and is therefore considered trapped. Unfortunately for the interpreting physicians, FDG PET has quite a few limitations. A major limitation is that it is not specific for cancer cells and is taken up by a variety of inflammatory conditions. In fact, there is a considerable overlap between many benign and malignant lesions. This becomes quite problematic in evaluating solitary pulmonary nodules and incidental adrenal nodules. Now, why is there an increased FDG uptake in inflammation? Because activated inflammatory cells show an increase in the number of glucose transporters as well as an increased affinity of these transporters for FDG. Various organs and tissues in the body rely on glucose as a substrate. So let us look at the normal distribution of FDG in the body. Highest uptake is in the brain. The kidneys and the bladder show intense uptake due to urinary excretion of FDG. There is moderate uptake in the liver and variable uptake in the heart, gut, salivary glands, and so on. Now, FDG Pep Ct is technically a challenging study as compared to other radiology studies. Various aspects have a potential for problems, including patient preparation, radiotracer injection, uptake period, image acquisition, and processing. I will discuss them one by one. As far as the patient preparation is concerned, SNM guidelines suggest a fasting period of 4 to 6 hours prior to PET imaging to ensure optimal insulin levels. Because insulin, whether endogenous or exogenous, can lead to increased uptake of FDG throughout the skeletal muscles of the body. Similar increased uptake is seen in patients on steroids and those who have recently exercised. This is a MIP image showing diffuse increased muscular uptake in a non-fasting patient. This altered biodistribution will affect the tumor to background ratio and mask the underlying disease. Similarly, artifacts can result from suboptimal injection technique of the radiopharmaceutical. A small amount of extravasation at the injection site is quite common. One must carefully look for the injection site when there is a small focus of increased tracer uptake in either the subcutaneous tissues of the arms or in one of the draining lymph nodes, for example, axilla. However, if a larger amount of tracer extravasates, it can cause more significant artifacts and the study may need to be replaced or repeated. A MIP image showing a large focus of FDG uptake in the right upper arm due to extravasation at the injection site. This extensive extravasation may lead to inaccurate SUV measurements as it decreases the amount of radiotracer in the blood pool. Misregistration artifacts, these are another potential pitfall and arise when patient position changes between CT and PET acquisition. A common artifact is caused by misregistration of PET and CT caused by respiration. A CT is usually acquired with breath holding, and a PET scan in quiet respiration. This may alter the position of organs, especially near the diaphragm. An example of respiratory motion artifact. These set of coronal images are showing two hypermetabolic liver lesions, one in the left lobe and other in the right lobe. Both are near the diaphragm and may be seen to project over the lungs. Attenuation correction artifacts can arise from metal or other high-density implants, as well as oral and IV contrast, because these high-density materials can create a false area of relatively increased tracer uptake. Now, how to clarify the situation? Two things might help. Number one, lack of consistent CT findings, and number two, review of non-attenuation corrected images. This artifact or increased activity should disappear on non-attenuated corrected images. These images show attenuation artifacts in the form of streaks. This particular patient did not remove her metal earrings. Lymphomas, as you know, are one of the more common indications for oncologic PET CT, and some of the most common histological subtypes include Hodgkin's lymphoma and DLBCL, and these are extremely FDG avid. However, there are other histological subtypes that are less or non-FDG avid, and these include large T cell, marginal zone, and small lymphocytic lymphoma. When performing initial staging PET CT, if you come across a non-FDG avid lymphoma, it is important to alert the treating physician to this fact so that he does not refer the patient for interim or end of treatment PET CT to determine treatment response. Quite a few cancers also show low FDG avidity, and knowledge of these is important to avoid false negative findings. These include hepatocellular cancer, renal cell cancer, neuroendocrine tumors, prostate cancers, and some genitourinary cancers. Now, let me talk about the variants, pitfalls, and artifacts seen in the pediatric population. Brown fat uptake has been reported in 1/3 of children and is more frequent in children and cold climates. It can be reduced by warming techniques. This image is showing a classic pattern of brown fat uptake in common locations, including bilateral cervical, supraclavicular, paraspinal, and upper abdominal region. FDG uptake in the bone marrow. Red marrow is metabolically more active than the yellow marrow and therefore demonstrates relatively increased tracer uptake. MIP image of a pediatric patient showing relatively increased FDG uptake in the proximal humeri, proximal and distal femurs, proximal tibias, all these reflecting the presence of red bone marrow at these sites. Thymus is usually visualized in children, adolescents, and young adults, with thymic hyperplasia occurring in the setting of severe stress or chronic disease. Intense uptake occurring after chemotherapy is known as thymic rebound. MIP image of a child showing uptake in the thymus above the heart. This uptake, as you can see, corresponds to a normal thymus on CT images. Another MIP image in a pediatric patient, the solid arrow shows normal uptake in the thymus, whereas the dashed arrow shows uptake in the lower cervical component. This cervical thymic extension is an important variant to recognize, wherein thymic tissue extends into the lower neck. Children also have prominent secondary lymphoid tissue, including the adenoids, palatine, and lingual tonsils. Moreover, they are more prone to low-grade FDG uptake in the reactive lymph nodes. Now, I will discuss the pitfalls that may arise in various regions of the body, starting with head and neck. Hypermetabolic brain lesions can result from a variety of cancers, including lymphomas, metastatic melanomas, or lung cancers. They may be difficult to evaluate due to the high physiologic FDG uptake in the brain. MIP images at 2 window levels showing a hypermetabolic lesion in left cerebellum. This lesion is hidden in the default window setting due to high FDG uptake in brain. It only becomes obvious when the window level is adjusted. This lesion is further confirmed on fused PET-CT image. Brain lesions without significant cystic or necrotic components, with significant cystic or necrotic components, may appear relatively photopenic. It is best to correlate such lesions with contrast-enhanced CT or MR. Other causes of photopenic defects include post-operative changes and prior infarcts. Axial PET image and contrast-enhanced CT image demonstrates a photopenic lesion on right side, which is actually a lung met. PET image demonstrates a wedge-shaped region of photopenia in the right parieto-occipital lobe, correlating to a prior infarct on CT image. Another set of images showing an infarct, that is a hypodense hypometabolic region in right parieto-occipital lobe. Asymmetric uptake in the pharynx in patients with no history of head and neck cancer poses a diagnostic dilemma, as both malignancy and inflammation can cause this, and there is no reliable absolute or relative SUV to differentiate between the two. Ultimately, clinical and endoscopic evaluation might be needed to exclude malignancy. Fused image shows focal uptake in the right fossa of Rosenmuller in a patient with metastatic lung cancer. This uptake was inflammatory and resolved on follow-up imaging. This is another example of focal nasopharyngeal uptake, 28-year-old female diagnosed as papillary thyroid cancer, status post-thyroidectomy, post-ablation with a negative iodine 131 whole body scan and a rising TG. The images show a hypermetabolic lymph node in right posterior parapharyngeal recess. CT could easily have missed this finding, though there is asymmetry in left and right parapharyngeal regions on CT. Uptake in vocal cords, when symmetric, poses no diagnostic challenge. However, focal asymmetric uptake may require further investigation. A common cause of asymmetric uptake is unilateral vocal cord paralysis, and one may need to look for the underlying cause, such as a thoracic or a cervical mass involving the nerve supply of the vocal cord. These images of the neck show intense FDG uptake in the right vocal cord. These images of the chest reveal the cause, that is, a hypermetabolic mass in the upper lobe of left lung, likely infiltrating the left recurrent laryngeal nerve. Brown fat in adults is also a common phenomenon and poses a problem when evaluating patients with head and neck cancers and lymphoma. A MIP image from InMole archives showing brown fat in bilateral neck and bilateral paravertebral region. These axial images of the same patient show hypermetabolic foci in bilateral posterior neck. Correlation with CT image helps resolve the problem as it corresponds to fat density regions and there is no corresponding soft tissue lesion. Now, what about the incidental uptake of FDG in the thyroid gland? This is quite common. Diffuse uptake is usually benign and is associated with conditions like Graves' disease and chronic lymphocytic thyroiditis. Rarely, diffuse thyroid uptake may be associated with malignancy like thyroid lymphoma and metastatic non-small cell lung cancer. Fused image shows diffuse thyroid uptake in a patient with Hashimoto's thyroiditis. Another example, a 45-year-old female with leiomyosarcoma uterus underwent treatment and came to us for restaging. All these images show diffusely increased laser uptake in both lobes of the thyroid gland. Further investigations confirmed the diagnosis of subacute thyroiditis. Focal FDG uptake in the thyroid gland, however, requires additional evaluation with ultrasound and possible tissue sampling because almost 1/3 of such cases have a sinister etiology, most commonly papillary thyroid cancer. PET and fused images show focal hypermetabolic uptake in the right lobe of the thyroid. Further evaluation with ultrasound was suggested. Images show focal FDG uptake in the right lobe of the thyroid gland. FNAC of the lesion showed it to be a papillary thyroid cancer. Muscle uptake in the neck is variable and mostly related to recent use, pain, anxiety, or inflammation. However, it must be minimized to avoid interpretation problems. PET and fused images showing increased FDG uptake in the muscles of mastication as a result of gum chewing. Therefore, most patient protocols request withholding eating and chewing gum prior to the exam. Incidental foci in the salivary glands may be encountered. In a study conducted by CO et al. In patients with head and neck cancer, focal FDG uptake was seen in the parotid gland in around 2% of the patients, out of which 1/3 had metastatic foci. Fused image shows focal FDG uptake in the left parotid gland. It remained stable for several years and was presumed benign. Fused image shows a hypermetabolic focus in the left maxillary sinus, which turned out to be a papilloma on tissue sampling. Next region is thorax. Let us look at the pitfalls commonly encountered in this region. Evaluation of a solitary pulmonary nodule is one of the most common indications for FDG PET-CT. However, smaller nodules pose a potential problem because they are beyond the spatial resolution of PET, which is around 7 to 8 millimeters. In addition to the small size of the pulmonary nodules, there are certain lung cancers which show low or no FDG avidity. These include adenocarcinoma in situ, carcinoid, as well as low-grade or early bronchogenic cancers. In case of metabolically inactive pulmonary nodules, CT surveillance is suggested according to Fleischner guidelines. These images show a soft tissue density nodule in the upper lobe of left lung, showing minimal misregistered FDG avidity. FDG avid inflammatory processes in chest are quite common and include pneumonia, tuberculosis, sarcoidosis, post-surgical and post-radiation inflammatory changes, talc pleurodesis, and esophagitis. Unfortunately, as previously mentioned, there is no reliable SUV threshold that can differentiate infection from malignancy. This is a case of sarcoidosis. Coronal fused image demonstrates FDG avid bilateral hilar lymph nodes and interstitial changes in the lungs. Another case of sarcoidosis, MIP image showing multiple hypermetabolic foci in the neck, chest, and abdomen. These images of the same patient show multiple hypermetabolic lymph nodes in bilateral mediastinal recesses. This is a case showing post-operative inflammation in an aortic graft. MIP and fused image reveal focal FDG uptake along the course of the recently placed graft. These images show post-radiation sequelae in a patient undergoing radiation therapy of the thoracic spine. There is increased FDG uptake in upper lobes of both lungs, more marked on the left side, with corresponding airspace opacities on CT image. FDG uptake in the myocardium is highly variable and can range from background to intense uptake. Axial PET image demonstrates a photopenic defect corresponding to an infarct in the apex of the left ventricle. Though heart is an uncommon site for malignancies, occasionally, METs can be seen in the form of hypermetabolic foci involving the left and right ventricles, as in this case of a melanoma patient. Finally, we come to this region of the body, that is abdomen and pelvis. FDG uptake in adrenal glands is important because they are a common site for metastases. However, quite a few benign etiologies show variable FDG uptake, including adenomas, myelolipomas, benign pheochromocytomas, hyperplasia, hemorrhage, and cysts. Again, no absolute SUV threshold exists for differentiating benign from malignant uptake. A common scenario is to come across an adrenal which is slightly bulky or slightly nodular, like in this case, where there is a subtle nodularity in left adrenal gland with mild FDG uptake. Patient with lung cancer, PET and fused images show mild FDG uptake in bilateral adrenal glands with nodular thickening. These findings correspond to benign nodular hyperplasia. This patient was diagnosed to have METs of unknown origin, status post lymph node biopsy of left supraclav region. MIP image shows multiple hypermetabolic foci in the chest with a possibility of a lung primary and nodal METs. However, it is the two discrete foci in abdomen which interest us right now. So let us see what these are. These images show well-circumscribed soft tissue density hypermetabolic lesions involving bilateral adrenal glands. So based upon their CT and PET findings, these are likely metastatic. FDG uptake in uterus and ovaries depends upon the patient's menopausal status. In premenopausal women, there can be physiological FDG uptake in the endometrium that varies with the menstrual cycle, with two peaks occurring during menstrual flow phase and ovulatory phase. This might be problematic in patients with cervical cancer. In such cases, it would be better to perform the PET-CT just before menstruation or after menstruation is finished. These images show FDG uptake in the uterine cavity. This is physiologic and consistent with patients' history of menstruation. Sagittal CT and fused images show intense FDG uptake in a large fibroid in the fundus of uterus. However, FDG PET cannot readily distinguish leiomyomas from leiomyosarcomas. Similarly, ovarian activity in premenopausal women can be physiologic and related to ovulation and corpus luteal cysts. This fused image shows an example of physiological focal uptake in the right ovary. Another example of physiological ovarian uptake, fused image shows a ring-like uptake in right adnexa, whereas CT image shows a rim-enhancing lesion corresponding to a corpus luteal cyst. A teaching point to remember is that in post-menopausal women, focal increased FDG uptake in either the endometrium or the ovary should be regarded with suspicion and should be evaluated further to exclude malignancy. FDG uptake in kidneys, ureters, and bladders may pose difficulty for the interpreting physician because this high physiologic uptake may obscure small disease foci. It is therefore advisable to adjust the PET window in order to avoid missing these subtle lesions. Pooling of radioactive urine in ureters is often difficult to distinguish from retroperitoneal or pelvic lymph nodes and must be reassessed in coronal and sagittal planes where the ureteric activity will appear elongated rather than round or ovoid as seen in a lymph node. MIP image showing pooling of radioactive urine in bilateral ureters. On axial image, this looks like two hypermetabolic foci anterior to the psoas muscles. However, on coronal PET CT and fused images, this activity becomes clearly elongated and can be localized to the ureters. This is a case of occult bladder mass. CT image demonstrates a subtle bladder mass, which is largely obscured on fused image due to physiologic FDG uptake in the urine. Another example of a diagnosed case of CA urinary bladder, the patient was sent to us for staging. The CT image shows thickening of bladder wall, more marked in the right lateral and the posterior wall. However, it is very difficult to comment upon the FDG ability of this thickening. An example of renal cell cancer, CT image shows a small exophytic lesion along the low pole of right kidney. On fused image, this lesion is difficult to pick up due to the increased physiologic uptake in the kidney. This means that FDG PET CT has a questionable utility in characterizing renal masses. FDG uptake in the bowel is highly variable. Physiologic activity in the bowel is typically diffuse and linear, whereas pathological uptake is often focal. Therefore, when focal uptake is identified, further investigation, usually with endoscopy, is recommended. Moreover, CT correlation should be done to look for an underlying inflammatory etiology. Images showing bowel uptake in Crohn's disease. Fused image shows focal FDG uptake in the right lower quadrant, which is localized on CT image to a short segment of small gut with wall thickening. Diffuse intense uptake in the bowel may be seen with metformin use, which is an oral diabetic medication. This may obscure malignant foci, and therefore it has been suggested to withhold the medication for 48 hours. MIP image shows metformin-related intense bowel uptake involving the distal small bowel and right colon. Urinary diversion procedures can also result in intense bowel activity. as FDG-avid urine enters the bowel. MIP image of a patient who underwent cystectomy, that is urinary bladder removal. You can see the intense FDG uptake in the right lower abdomen due to FDG-avid urine being diverted into a urostomy with an ileal conduit. Good news, fellows, because this is the last section of pitfalls. So let me show you some associated with musculoskeletal uptake. FDG uptake is seen in both pathological and non-pathological fractures. Correlation with corresponding CT image is suggested to look for a benign or malignant etiology. If the focus of uptake remains indeterminate, then MR correlation may be considered, or alternatively, follow-up PET CT may be suggested as activity in benign post-traumatic or post-surgical fractures, usually normalizes over several months. An example of a focal FDG uptake in a benign rib fracture in left rib posteriorly. Diffuse bone marrow uptake is often related to bone marrow stimulation with drugs. In such cases, history of marrow stimulating drugs is important. However, occasionally, this diffuse bone marrow uptake can hamper treatment assessment. This example will make it clear. First MIP image shows innumerable hypermetabolic osseous nets. The second MIP image shows an after-treatment scenario. There is diffuse increased FDG uptake throughout the bone marrow of the visualized skeleton, making it rather difficult to comment upon the treatment response. FDG uptake in the marrow of the irradiated region is usually decreased. Therefore, knowledge of radiation history and radiation location is important to identify this unusual pattern of uptake. At the same time, the interpreting physician must be careful not to misinterpret the normal non-irradiated marrow as pathologic. Sagittal images showing post-radiation sequelae, that is, reduced tracer uptake in the bone marrow of the thoracic spine. I suppose that should be all as far as the pitfalls are concerned, so kindly wake up. Now I come to the more interesting part of my talk. I will be showing you a few clinical cases from InMole PET CT archives. I will walk you through simpler cases first: lymphoma staging, lymphoma treatment evaluation, followed by lesion localization for biochemical recurrence in differentiated thyroid cancer and ovarian cancer, plus some cases of lung cancer staging. So have patience. All things are difficult before they become easy. This, by the way, is not my saying, but the saying of the famous Persian poet Abu Muhammad Shirazi, also simply known as Sadi. This is going to be the format of image display. In each case, I will be showing you a MIP image followed by a set of 3 images, that is PET, CT, and fused images. So this is the first case. The patient was diagnosed to have non-Hodgkin's lymphoma, and he was sent to us for staging. MIP image clearly reveals hypermetabolic nodal disease above and below the diaphragm. That makes it stage 3 or advanced lymphoma. Now let us look at the axial, PET, CT, and fused images of the same patient. They show an enlarged hypermetabolic lymph node in left axilla. This particular set of images show an enlarged hypermetabolic lymph node in the left external iliac region. Case number 2, 67-year-old female diagnosed as Hodgkin's lymphoma on biopsy of right cervical lymph node. She was sent to us for staging initially and then for treatment response evaluation. Here you see two MIP images, the first one from staging PET CT and the second one from end of treatment PET CT. The images, of course, speak for themselves. The patient has shown good response to chemotherapy and appears to be in complete metabolic remission. Axial images of the neck of the same patient show multi-level enlarged hypermetabolic lymph nodes in the right neck, including right supraclav region. This is, of course, the baseline PET image. Axial images skeletal uptake. FDG uptake is seen in both pathological and non-pathological fractures. Correlation with corresponding CT image is suggested to look for a benign or malignant etiology. If the focus of uptake remains indeterminate, then MR correlation may be considered, or alternatively, follow-up PET CT may be suggested as activity in benign post-traumatic or post-surgical fractures, usually normalizes over several months. An example of a focal FDG uptake in a benign rib fracture in left rib posteriorly. Diffuse bone marrow uptake is often related to bone marrow stimulation with drugs. In such cases, history of marrow stimulating drugs is important. However, occasionally, this diffuse bone marrow uptake can hamper treatment assessment. This example will make it clear. First MIP image shows innumerable hypermetabolic osseous nets. The second MIP image shows an after-treatment scenario. There is diffuse increased FDG uptake throughout the bone marrow of the visualized skeleton, making it rather difficult to comment upon the treatment response. FDG uptake in the marrow of the irradiated region is usually decreased. Therefore, knowledge of radiation history and radiation location is important to identify this unusual pattern of uptake. At the same time, the interpreting physician must be careful not to misinterpret the normal non-irradiated marrow as pathologic. Sagittal images showing post-radiation sequelae, that is, reduced tracer uptake in the bone marrow of the thoracic spine. I suppose that should be all as far as the pitfalls are concerned, so kindly wake up. Now I come to the more interesting part of my talk. I will be showing you a few clinical cases from InMole PET CT archives. I will walk you through simpler cases first: lymphoma staging, lymphoma treatment evaluation, followed by lesion localization for biochemical recurrence in differentiated thyroid cancer and ovarian cancer, plus some cases of lung cancer staging. So have patience. All things are difficult before they become easy. This, by the way, is not my saying, but the saying of the famous Persian poet Abu Muhammad Shirazi, also simply known as Sadi. This is going to be the format of image display. In each case, I will be showing you a MIP image followed by a set of 3 images, that is PET, CT, and fused images. So this is the first case. The patient was diagnosed to have non-Hodgkin's lymphoma, and he was sent to us for staging. MIP image clearly reveals hypermetabolic nodal disease above and below the diaphragm. That makes it stage 3 or advanced lymphoma. Now let us look at the axial, PET, CT, and fused images of the same patient. They show an enlarged hypermetabolic lymph node in left axilla. This particular set of images show an enlarged hypermetabolic lymph node in the left external iliac region. Case number 2, 67-year-old female diagnosed as Hodgkin's lymphoma on biopsy of right cervical lymph node. She was sent to us for staging initially and then for treatment response evaluation. Here you see 2 MIP images, the first one from staging PET CT and the second one from end of treatment PET CT. The images, of course, speak for themselves. The patient has shown good response to chemotherapy and appears to be in complete metabolic remission. Axial images of the neck of the same patient show multi-level enlarged hypermetabolic lymph nodes in the right neck, including right supraclav region. This is, of course, the baseline PET image. Axial images of the abdomen show a solitary FDG-avid lymph node in the pre-cable region. Heterogeneous hypometabolism was also identified in the spleen. After having received 6 cycles of chemo, the patient was sent to us for restaging, and I showed you these comparison images earlier as well. So these are baseline and end of treatment CT and fused images of the neck. They show that the previously documented nodal findings in the right neck have undergone complete metabolic and almost complete morphologic resolution. Baseline and end of treatment CT and fused images of abdomen. These show that the previously noted FDG-avid lymph node in pre-cable region has also resolved. Case number 3. Hodgkin's lymphoma diagnosed on left supraclav lymph node biopsy. She underwent 4 cycles of chemotherapy and was sent to us for interim PET for response evaluation. Again, in this image, you see 2 MIP images, the first one from staging PET CT and the second one from interim PET CT. Once again, the images speak for themselves. The patient has shown good response to chemotherapy and appears to be in complete metabolic remission. What you see in neck in the second MIP image is brown fat. Here are 2 sets of images pertaining to this case. Kindly look at them carefully. The baseline images of neck show multi-level enlarged hypermetabolic lymph nodes in left neck, including the left supraclav region. After 4 cycles of chemo, these nodal findings have undergone complete metabolic resolution and significant morphologic resolution as well. The yellow arrows that you see on the images are showing FDG-avid foci in posterior neck. These are due to brown fat because on CT image, they clearly correspond to the brown fat region. Again, 2 sets of images of the chest region. The baseline images show multiple enlarged and fluent hypermetabolic lymph nodes in the mediastinal recesses. After 4 cycles of chemo, these nodal findings have undergone complete metabolic resolution and significant morphologic resolution as well. To conclude from these cases of lymphoma, FDG PET is the current state-of-art imaging in lymphoma and plays a central role in treatment decisions. Now, I will show you a few cases of differentiated thyroid cancer, mainly papillary thyroid cancer, as it is the commonest. The scenario for DTC is almost always the same: post-thyroidectomy, post-ablation, elevated TG levels, and a negative iodine whole body scan, the so-called tennis syndrome. The patients are referred to us for PET CT to look for the source of elevated TG levels. Case number 4, 61-year-old female. As we are rather pressed for time, I will not go into the case details, but will just show you the positive findings. Images of neck showing sub-centimeter sized lymph nodes with mild FDG avidity in bilateral upper level 2 neck region. Images of the chest showing a pulmonary nodule with mild metabolic activity in left lung base. Case number 5, 48-year-old male, Interestingly, this patient had elevated anti-TG levels instead of TG levels and a negative iodine whole body scan. Hypermetabolic lymph nodes can be appreciated in bilateral level 2 neck region, as well as in bilateral level 4 neck region. Case number 6, 49-year-old male. On the MIP, you can just appreciate 2 hypermetabolic foci. Let's find out what these are. There is a hypermetabolic lesion adjacent to the right tonsil and a hypermetabolic lymph node in left paratracheal region. Case number 7, 64-year-old female. A small, solitary, sub-centimeter sized FDG avid lymph node in the left level 4 neck region and FDG avid lymph nodes in right paratracheal region. There are 2 subpleural nodules, one having mild FDG avidity in upper lobe of right lung. So all these findings were responsible for secreting the thyroglobulin. Case number 8, 63-year-old female, and the MIP image shows just a small, solitary hypermetabolic focus in right chest. Let us see what this is. So the only FDG avid focus in this patient was a pulmonary nodule in the right upper lung. In all these 5 cases of papillary thyroid cancer, we saw one thing. The commonest sites of disease recurrence are the cervical lymph nodes. Systemic or distant mets are rare and account for less than 10% of the cases. As we have seen that FDG Pet CT does play a valuable role in post-thyroidectomy workup of patients with DTC who have elevated TG levels and a negative iodine whole body scan. This subset of patients poses a diagnostic and therapeutic dilemma because disease localization can be difficult. As the DTC cells or the cancer cells dedifferentiate, their radioiodine uptake generally decreases and the glucose metabolism increases. This flip-flop phenomenon is not always present. Though PTC is the most frequent of thyroid cancer, the good news is that it has the best prognosis and is one of the best treatable cancers. Now, let me move on to another type of cancer where biochemical recurrence is important. I will be showing you a case of ovarian cancer with rising CA125 levels, but a negative contrast-enhanced TT and MR. I will again skip the case details. 60-year-old female diagnosed to have bilateral ovarian cancer. Images show 2 FDG avid peritoneal deposits in subphrenic region, one to the right of midline and the other along the right subcostal region. You can see multiple FDG avid deposits, primarily in the right side of abdomen. And these are inseparable from adjacent gut loops. So these are likely subserosal deposits. These images show a solitary discrete peritoneal deposit with mild FDG avidity in the pelvis. You can see a solitary lymph node with mild FDG avidity in the porta hepatis. In these images, you can appreciate a subcapsular liver deposit in segment 4. So to conclude, we have seen multiple FDG avid peritoneal and subserosal gut deposits, FDG avid lymph node in porta hepatis, and FDG avid subcapsular liver deposits. All these findings are suggestive of disease recurrence. Now, in the end, I will show you a few cases of lung cancer. That is non-small cell lung cancer, which accounts for 85% of all lung cancers. Let us look at the role of PET-CT in staging of these cancers. This is a MIP image of a 64-year-old male, and it is showing multiple hypermetabolic lesions in neck, chest, and abdomen. So the images show a hyperdense hypermetabolic lesion in right cerebellum. There is a hypermetabolic nodule in left thyroid lobe. Look at the white arrow. And then there are hypermetabolic lesions in the cervical spine as well as the right scapula. There is a soft tissue density hypermetabolic lesion in upper lobe of left lung. This is consistent with the primary tumor. These images show hypermetabolic lesions in the skeleton, that is the left iliac bone and sacrum. So how has the PET-CT been superior in this case? Let's see. It has scanned the entire body from skull to mid-thighs in a single study. It has discovered distant metastases in skeleton and nodal sites of neck, chest, and abdomen. It has discovered a possible rare site of metastasis, that is thyroid, and it has also discovered brain metastases. Case number 11, 71-year-old male diagnosed to have lung cancer on transbronchial biopsy. And mostly I have shown you the anterior MIP images, but in this case, I will be showing you a posterior MIP image as well. And you can see a solitary focus in the right side of the abdomen. Let us find out what it is. It actually is a hypermetabolic nodule in the right adrenal gland. Images of the same patient showing hypermetabolic mass in the right lung, which is consistent with known primary. And you can also see hypermetabolic lymph node in the subcarinal region. This is already documented on CT. So how is the PET-CT superior in this case? PET-CT has discovered a possible adrenal met and has upstaged the disease from T2B N2 to T2B N2 M1B, meaning a single extrathoracic met. This, I believe, is the last case. 69-year-old male diagnosed to have adenocarcinoma on endobronchial biopsy. The MIP image reveals a solitary hypermetabolic focus in the left chest. And these images show a soft tissue density hypermetabolic mass in the left lower lobe. The stage comes out to be T2, N0, M0, making it a resectable disease. So to conclude, let us look at the role of FDG PET-CT in the management of lung cancer. Well, it results in more accurate staging. It is more precise than CT in its ability to assess locoregional lymph node spread. It can detect metastatic lesions that would have been missed on CT alone. That is all. Thank you for your attention and patience. Thank you very much again.
Very thankful to Dr. Abdul Fatma for this comprehensive talk on PET-CT. I think all the panelists and attendees have joined the teaching file session. So, Dr. Ardu, are you there so that we can move on for the question answer session?
Yes, can you hear me, Dr. Awais?
Yeah.
Okay, first of all, I would like to express my thanks to all the organizers, especially to you two for such nice moderation and for holding this session. And it will be my pleasure to take up all the comments and the questions that are there. So let's begin.
So the first question is by Dr. R. Zahid Charab. He's asking, he just want to know that photopenic area in the brain especially
Yeah.
in the pediatric population. Why
Mhm.
is it labeled as a pitfall, not a finding? Like
Actually,
when this yeah,
have you completed the question?
the question is complete that the photopenic area in the brain, in a pediatric
Yeah.
brain, you
Yeah.
label it as a pitfall, not a finding.
Actually, it is not just related to the pediatric brain. Photopenic area or a hypermetabolic lesion in the brain is difficult to pick up because, like I mentioned, brain is an obligate user of glucose. And so there is an intense uptake of glucose or FTG on the PET images. What we need to do is look carefully at the CT window and to look it up in the brain window, not to miss these lesions. Because usually what we do is that we just, scroll down the brain quickly. But if we look very carefully, and this is not just relevant to the pediatric population, in fact, you see these lesions, I think I showed them pertaining to the artifacts in the head and neck, not in the pediatric population, because normally you do not see these things in the pediatric population. Infarcts or other, tumor-related photopenic post-surgical changes we come across in the adult population, right?
Okay. And next question is by Dr. Umair Sajjad. He just wants to know if there is any uptake in the thyroid in the post-immunotherapy status. Any experience of having post-immunotherapy thyroid FDG uptake?
Actually, we do not get referrals for this. And what we see in the thyroid is basically an incidental finding. We mostly get a referral for oncological, staging, response evaluation, and restaging. And during that, we sometimes come across either diffuse pattern of uptake in the thyroid gland or focal pattern of uptake. And like I said, when we see a diffuse pattern of uptake, we are not that alarmed because it usually has a benign etiology. But when we see a focal uptake in one of the lobes of the thyroid gland, we then become a little alarmed and we suggest further evaluation. But as far as immunotherapy is concerned, I do not think that we get that many referrals or that we do PETs for that indication.
It might be biphasic then.
Excuse me, I beg your pardon?
It might be the biphasic pattern like thyroiditis, the biphasic pattern of the uptake.
I'm not sure about that, but I think we need to look it up.
Okay, the next question is by Dr. Shazia Fatma. She just wants to know any COVID-related uptake in the lung. As we can see, the HRCT findings. So, do you have any experience of FDG uptake in the lungs in a COVID patient?
Yes. We actually came across quite a few patients, in the second wave and even in the first wave. And we saw that there were, up FDG diffuse uptake, which was corresponding to a interstitial pattern on the CT. And it was more in the domain of the radiologist. And we would then discuss these findings along with the clinical history with the radiologist and would either give a sort of a comment upon infective or inflammatory etiology in the COVID scenario.
And is there any standard policy at your institute when once you see such findings, which are typical for a COVID pathology in the lung, how do you respond? Do you have any protocol designed how to handle such patients?
Actually, these patients are then communicated these findings and they are advised, if they had not already undergone and they are not aware of their condition, to go for a PCR test for COVID. And then observe obviously the precautions that they're supposed to go into.
What about the system and the radiation technologists working over there?
Already our technologists are wearing all the desired, kits, the protective layers, double mask, shields, and the gowns. And when they come across such findings, we communicate to them as well. And the doctor who has taken the history, so that they also, if they want to, because they also normally are wearing gloves and all the, protective gear. But I suppose retrospectively, that is all that you can do.
One more question by Dr. Shazia Fatma that she wants to know how long these post-radiation changes persist on a PET scan.
I'm not too sure about that because these patients obviously do not come to us for a follow-up that quickly.
Okay. Dr. Umar Khan wants to know about your thoughts regarding FDG uptake in patients non-AV disease process in lymphoma patients which are non-AV disease that are FDG avid initially, but after therapy, if these were initially non-AV disease process, is there any possibility that non-AV becomes AV? Okay. He just wants to know that is there any possibility that initially a lymphoma patient which is not showing any avidity of FDG uptake on PET scan, he or she may become positive post-therapy scan.
Like I mentioned earlier, that when these patients come to us for staging PET, and on staging PET, if we come across a lymphoma that is not showing any avidity, we raise an alert to the treating physician that it would be better to follow this patient on CT. But if for some reason or another, they again send the patient to us and we see that those nodal findings or extranodal findings have now become FDG avid, then this means that likely the lymphoma has undergone a aggressive transformation and it has now started to take up FDG.
Okay.
But I personally have not really seen such a pattern, a lot here. In fact, I cannot recall a case that comes to my mind right now.
The next question is by Dr. Muhammad Asif Shafiq. He just wants to know how to interpret the FDG uptake with normal CT finding in a bone.
With normal
CT finding.
Yeah, that is a very good question because, if you are having FDG uptake in the skeleton and you are having no corresponding CT findings, then this means that it is most likely the bone marrow involvement.
Okay. So one should think about some pathology in the bone marrow if the bone is appearing normal on the CT.
Yeah, pathology means that if we are talking in terms of lymphoma, then most probably it is lymphomatous involvement of the bone marrow and not the cortical bone at that point in time.
Got it. One of the panelists has asked that how to take history of the patient and any special point which resident should ask before you inject the PET radiotracer, and what are the indications of PET in the brain, and when to stop metformin before the scan. He asked 3 questions basically.
Okay, let me address the first one. Which one was that?
History. Any particular thing in the history one should ask before.
To what? Pertinent to what?
Pertinent to, I think, because his third question is about the metformin. So I think regarding the diabetes or the sugar level.
Okay, so obviously when diabetic patient comes to us, we make sure that the patient is well controlled, because this is very important. Like I mentioned in my pitfalls, that if the patient is having a high blood sugar level, then obviously this is going to compete with FDG uptake, and you will see an altered biodistribution, and consequently our target to background ratio is going to be disturbed, and the disease or the lesions are going to be masked. So it is very important in the history that we know that the patient, if he or she is diabetic, is well controlled, what sort of insulin preparation the patient is taking, because that also we need not, patient should not be having that insulin 2 hours prior to the test, because insulin, like I mentioned, whether it's endogenous or exogenous, can also cause an increased uptake of the FDG in the skeletal muscles. And then we need to know if the patient is on any oral anti-diabetic medications, like I told you, metformin, because metformin, interestingly, causes a very intense uptake in the bowel. And the mechanism, though not very clear, there have been several postulations. Most probably, it increases the transport of glucose from the vascular compartment to the epithelium or the mucosa of the bowel. And this is due to the translocation of the glucose transporters, which are normally present inside the cells, in the vesicles. and these get transported to the membrane. So we need to know on what sort of medication the patient is. This is as far as the diabetic patient is concerned. Otherwise, like I said, that in a patient, generally, the patient should be fasting. A fast of 4 to 6 hours is recommended. And this is also for the same reason, right?
There is repetition of one question. That
Yes.
immunotherapy results in thyroid malfunction. Immunotherapy may cause hyperthyroidism or thyroiditis, but thyroiditis is more frequently observed. So,
Right.
But the question is still not clear. But someone has asked.
If in all cases of, not in all cases of thyroiditis, you are going to see increased uptake of FTG. But like I said, that if you incidentally come across a diffuse pattern of uptake, what you can do is you can go for further evaluation, like maybe the thyroid function test or thyroid antibodies, if you are really interested in elucidating the etiology behind this.
Last question by Dr. Shazia. She wants to know about how to disinfect the camera. And secondly, in cardiac PET studies, what you prefer for patient preparation?
How we disinfect the camera in the COVID scenario.
Yeah, in the COVID scenario.
Yeah. Well, every day before we start the studies, we spray the cameras, the desktops, the surfaces which are likely to be handled by the doctors, the technologists, as well as the patient. And then when we have because we do these patients from sort of morning till evening. So at the end of the day, even we make sure that all these surfaces are sprayed again. And if we come across a patient in which we suspect that this patient might be having a COVID lung, in that case, we follow all these things after that patient is moved from the patient bed. And then we continue with the next patient.
And last question is, in cardiac PET studies, what do you prefer for patient preparation? Any special preparation?
Actually, we are not right now doing a lot of cardiac PET. I think this question is beyond the scope of this talk right now.
Got it. So at the end, I thank you for your presentation, especially for the teaching files. Thank you again on the behalf of PSNM for especially all the speakers. And at the end now, once we have done with all the talks, so our Director PNM, Dr. Mohammad Baba Imran, is right here with us. So I request Dr. Mohammad Baba Imran to please.
Dr. West, can I just one comment, if you can allow me?
Gigi, madam, please. Speak.
Actually, if there are some more comments or questions that have not been put up right now, I'll be more than willing. It will be my pleasure, in fact, to answer them. And they can send them to you via the email, and then I can take them up and answer them.
So nice of you. So your message has been conveyed to all the panelists. And that
yes,
is,
thank you again.
If anyone has any query or any other question in his mind, so please do mail to Dr. Arju Fatma. Thank you, Dr. Arju. Once again, we really appreciate your efforts for this workshop.
The pleasure is very much.
Moving to the concluding session, I request Dr. Mohammad Baba Imran, Director PNM, for his remarks.
Bismillahirrahmanirrahim. Assalamu alaikum and good day to everyone. I suppose something like 80 to 100 participants were there online, and it's really a pleasure to share these sort of talks with a lot of people online. And in this era of disaster, along with the development of technology, we have reached to this point that many people, they can join us even from their workplace. And the speaker as well, they are there at their workplaces, and they can share their views, their opinions, and their expert lectures. Actually, I feel proud that I'm concluding this very nice workshop and session, which is organized by Dr. Awais from PNM and Dr. Faisal X from PNM. At present, he is at Inmo. We have tried our best that Dr. Faisal should come and frequently visit us at Pinham and can manage and arrange many academic activities for nuclear physicians from the forum of PSNM and from the forum of Pinham as well. But unfortunately, we couldn't argue and pursue a lot of times. And probably he was not very much of the person probably teaching to nuclear physician at that time. And I've seen that he is very fond of teaching to radiologists. I'm not sure what is the reason, whether this is the radiology specialty or the radiologists themselves, because there is preponderance of certain gender in the radiologists at that time. And Dr. Akif, are you there? Probably now that gender differences are also seen now in the nuclear medicine specialty as well. So probably these two giants and these two stars, now they have started teaching nuclear physicians as well. Anyway, ladies and gentlemen, we started this journey in mid-90s when PET was coming from the research benches to the clinical benches. And at that time, it was only PET scanner and PET scans. And we had externally placed radioactive source, probably sometimes germanium rod, which was being used for the attenuation correction. Later, this was replaced with the CT tube, and it became a permanent source instead of replacing the source every 2-3 years. And then someone very intelligent and genius person thought that why not to use this map for attenuation? In addition to attenuation correction, we can use this for the localization purpose. So from attenuation to localization. And at that time, we came to an era where Google Map can lead to anywhere to unknown place as well. So this part of the radiology and the radiologists, they help us this hybrid imaging to a newer horizon where we can exactly localize where the problem, where the hypermetabolic area is. And then further going further, this localization led to characterization of the lesion. So alhamdulillah, now we are there that this hybrid imaging, of which the major stakeholders are, of course, nuclear physicians, they can get help from the radiology and radiologists to not only to localize, to make the unclear to more clear, and also to characterize the lesions. Anyway, I'm very thankful to all the speakers who have shared their expert opinions, and they have spared a lot of time for PSNM, for the nuclear physician, and all those who were online. It was really clear to see that some of the participants, they were very active, and one of them was actually hyperactive. Now you can localize who was that. Anyway, with this comment, I'm thankful for the organizer. They have given me a chance to conclude this session. Thank you very much. One suggestion is that we should continue these sessions from the forum, from the platform of PSNM, as well as from the platform of individual centers. Now, without spending a lot of resources, we can manage these sessions, especially for our youngsters, especially the upcoming and rising stars in the nuclear medicine. Thank you very much. Assalamu alaikum.
Thank you, Dr. Mohammad Baba Imran. At the end, I thank all the attendees and the participants for their patience listening. And with these remarks, we end today's session. And hope so you will join us tomorrow at 9 a.m. sharp in the morning, as we have a 3-day conference ahead. Thank you again. See you tomorrow, inshallah. Take care. Allah Hafiz.